Let's look at the clinical features of clavicle. First is the fracture of clavicle. Here's your collarbone or clavicle. It contains two parts. This much is the lateral part of the clavicle, which forms one third of the clavicle, and this much is the medial two-third of the clavicle. At the junction between the lateral part and the medial part of the clavicle, it is most susceptible to fracture. So the most common area of fracture is the junction between the lateral portion and the medial portion of the clavicle. As you can see in this X-ray, a fracture has occurred of the clavicle, and this fracture has occurred at the junction between the lateral portion and the medial portion. The medial fractured part is lifted with the help of sternomastoid muscle. However, the lateral fractured part has displaced downward from its original position due to the weight of the arm. Next is cleidocranial dysostosis. Dys refers to disorder and ostosis refers to ossification of bone. If there is any kind of disorder during the ossification of bone, that's what's called dysostosis. Cleidocranial. Cleido refers to collarbone or clavicle and cranial refers to cranium. Both clavicle and cranium show membranous ossification. If any kind of defect is seen during the membranous ossification of cranium or clavicle, that's what's called cleidocranial dysostosis. There are three cardinal features of cleidocranial dysostosis, and they are: number one, aplasia of clavicle. Due to aplasia of clavicle, the clavicle either goes missing or there is poor development of clavicle. As you can see in this person with cleidocranial dysostosis, there is absence of clavicle. That is why he is able to bend his body in such a way. As you can see in this X-ray, the clavicle was supposed to be here, however it is absent. And this is what we call aplasia of clavicle. So the clavicle is either missing or there is very poor development of clavicle. Second cardinal feature is the increase in transverse diameter of cranium. Here's the cranium, here's the transverse plane on which the cranium lies, and here's the diameter through the transverse plane. The diameter in the transverse plane of the cranium increases. Third cardinal and the last cardinal feature is retardation in fontanelle ossification. Fontanelle is basically the soft spot present on the cranium of the baby. So here's one fontanelle, here's one fontanelle. The fontanelle needs to go through the process of ossification so that it can get replaced by bone. However, during this condition, that is cleidocranial dysostosis, the fontanelle does not want to go through the process of ossification, or there is a retardation in fontanelle ossification, so the fontanelle remains as it is. During X-ray, it seems as if there is a fracture on the cranium. However, the reality is that this much part has not ossified yet, or the fontanelle has not ossified yet. It is not a fracture, it's just that the fontanelle has not ossified here. So the bone is not visible through an X-ray. Now let's look at the clinical features of scapula or clinical anatomy of scapula. Winging of scapula. This serrated muscle right here, which is present anterior to scapula, is the serratus anterior muscle. In this guy right here, the serratus anterior muscle is present right here. It is serrated and present in front of the scapula, so called serratus anterior. The serratus anterior muscle is responsible for connecting the anterior surface of the scapula with the costal region or costal surface tightly. However, due to weakness or maybe due to paralysis of this muscle, the costal surface of the scapula is unable to fit tightly. This leads to winging of scapula, and it looks something like this. Here, the guy is suffering from winging of scapula on one side. Here, the scapula is tightly attached with the costal region due to the proper functioning of serratus anterior muscle. However, at this portion, the serratus anterior muscle is either weak or maybe suffering from paralysis, due to which there is limited ability to stabilize the scapula. The scapula is not properly stabilized, and it seems as if it is trying to pop off or come out of the body, as if wings are trying to form, and that's why it's called winged scapula. Serratus anterior muscle weakness or paralysis leads to limited ability to stabilize the scapula. As a result, the medial or lateral borders of the scapula protrudes from back like wings, and that's why this is called winged scapula. Second is scaphoid scapula. Scaphoid refers to boat shaped. During this condition, here's the normal scapula. This is the medial border of the normal scapula, which is almost straight. However, in scaphoid scapula, the medial border becomes concave. That is why it looks like a boat. It looks like a boat. And this scapula right here is called the scaphoid scapula. Let's look at the clinical anatomy of humerus. The most common sites of fracture in humerus are the surgical neck of the humerus, the shaft of the humerus, the supracondylar region of humerus, and the medial epicondyle of humerus. Surgical neck fracture may lead to an injury to axillary nerve. Shaft fracture may lead to an injury to radial nerve. Medial epicondylar fracture may lead to an injury to ulnar nerve, and supracondylar fracture leads to something called Volkmann's ischemic contracture. And we need to know what Volkmann's ischemic contracture actually is. Let's suppose this guy right here goes through an unfortunate accident. He falls on his outstretched hand, that is, the hand is stretched outward. As a result, the supracondylar region of the humerus fractures. Just anterior to supracondylar region or anterior to humerus is an artery that supplies blood to your forearm called the brachial artery. A fracture of supracondylar region of humerus leads to an injury to brachial artery at the region of fracture. The artery either gets teared or pressed or some kind of occlusion takes place. Either way, the blood supply to forearm muscles decreases, and a decrease in the blood flow through artery is called ischemia. So an injury to brachial artery due to fracture of supracondylar region of humerus leads to ischemia to forearm. Prolonged ischemia or prolonged lack of blood supply to forearm leads to contracture of forearm muscle. Contracture basically means that the forearm muscles, they decrease in size and become solid or harden. Due to the decrease in the size of the forearm muscle and hardening of the forearm muscle, clawing of fingers and thumb takes place, and basically the forearm gets wasted. So what happens during Volkmann's ischemic contracture? During Volkmann's ischemic contracture, due to fracture of supracondylar region of humerus, injury to brachial artery takes place, which leads to ischemia, and ischemia leads to contracture of forearm muscle, that is the muscle of the forearm due to the lack of blood shortens and become hard, and due to the shortening and the hardening of forearm muscle, clawing of thumb and fingers take place, and the forearm muscle gets wasted. Let's look at the clinical anatomy of radius. There are two types of fracture of radius that you need to know. One is Colles fracture and the other is Smith fracture. Colles fracture of the radius takes place when a person falls on an outstretched hand. An outstretched hand looks something like this. That is, the palm is facing the ground. During Colles fracture, the distal part of the fracture, it displaces upward and backward, as you can see in the diagram. Upward and backward. Next is Smith fracture. Smith fracture takes place from a fall on a flexed wrist. That is when the wrist is flexed like this and the tension is applied somewhere here. The distal part of the fracture moves anteriorly, as you can see in the diagram. So there's your Colles fracture and Smith fracture. Colles fracture takes place due to a fall on an outstretched hand. Smith fracture takes place due to a fall on a flexed wrist. During Colles fracture, the distal part of the fracture moves upward and backward. During Smith fracture, the distal part of the fracture moves anteriorly. Next is pulled elbow. In a child, the annular ligament that holds the radius and the ulna together is not well developed yet. As a result, if you try to lift a child by his arm, then tear to the ligament may occur. Due to the tear to the annular ligament, the radius slips partially from its original position. Now let's look at the clinical anatomy of ulna. During dislocation of elbow, the olecranon process of ulna is shifted or displaced posteriorly. As a result, the elbow is kept in a slightly flexed position. The fracture of olecranon process of the ulna is quite common. However, the fracture of coronoid process is not that common. So in a typical condition, the radius and ulna they grow together. However, during Madelung's deformity, the radius at the lower end stops its growth. As a result, the radius becomes short in size and bowed, due to which the ulna is forced out of position. So as you can see in this particular X-ray, the radius stops growing, due to which the ulna is forced out of position. It is forced out of position. The radius doesn't grow. It becomes short and bowed. Ulna is pushed out of position. Dorsal subluxation or displacement of the lower end of ulna takes place. Due to the retardation in the growth of the lower end of radius, the lower end of the ulna gets pushed dorsally, pushed dorsally, pushed dorsally, pushed dorsally. Let's look at the clinical anatomy of carpal. The most common fracture of carpal bone is that of scaphoid carpal. So the scaphoid carpal is a boat-shaped carpal that is present right here, and this carpal is most susceptible to fracture out of all other carpals. Let's look at the fractured scaphoid bone zoomed in. Here's the scaphoid carpal. Here's the radial artery that supplies blood to your hand. From the radial artery arises a branch that supplies blood to your scaphoid bone. Let's say the scaphoid bone gets fractured at this region. After fracture, the branch supplying blood to the scaphoid bone also gets injured. As a result, this portion of the scaphoid bone, which is the proximal portion of the scaphoid bone, does not receive any blood. It goes through necrosis and the proximal portion dies. Carpal tunnel is a tunnel which is formed by the carpal bones at a region just above your wrist. At this particular region, carpal tunnel is present. So here's the carpal tunnel. The carpal tunnel contains the median nerve. If pressure is exerted or accumulated inside the carpal tunnel, the median nerve gets compressed. The median nerve gets compressed. As a result, this much part of the hand suffers from numbness or pain, and that's what we call carpal tunnel syndrome. Now let's look at the clinical anatomy of metacarpal. Here's the first metacarpal, second metacarpal, third, fourth, and fifth metacarpal. This is the head of the first metacarpal and this is the base of the first metacarpal. A fracture at the base of the first metacarpal is called Bennett fracture. So Bennett fracture is the fracture of base of first metacarpal. In children, the metacarpal is highly vascular due to the supply of nutrient artery. As a result, there's a high chance of tubercular or syphilitic infection through the blood supply of the nutrient artery. However, in adult, the nutrient artery gets replaced by periosteal vessels. As a result, the chances of tubercular or syphilitic infection to metacarpal decreases. Polydactyly is the condition of presence of an extra digit, like you can see in this particular condition here as well. The metacarpal, it bifurcates and forms an extra digit. Now let's look at the clinical anatomy of phalanges. So here are your 5 fingers as shown by the x-ray. This finger right here is the middle finger. The middle finger contains 1, 2, 3 phalanges. This is the proximal phalanx, this is the distal phalanx, and here's the middle phalanx. As you can see, the distal phalanx of the middle finger is fractured. So this phalanx right here, that is the distal phalanx of the middle finger, is the phalanx that is most commonly fractured. So this phalanx, distal phalanx of middle finger, is most commonly fractured. It can be treated using a splint. So this is the middle finger with the fractured phalanx, fractured distal phalanx. The finger with the fractured phalanx is bodied together with an adjacent finger using a splint. And this is what we call body splint of fingers, which helps in healing of the fractured phalanx.